a week. Why did we hit 2,000 a week? It's very simple. We fell in love with actually transforming people's lives. We fell in love with spinal reconstruction. We loved adjusting. We loved being in practice. We loved just being who we were designed to be.
Your hosts today are Doctors Ed Quirk and Yuri Chupa. Go ahead, doctors.
G'day, warriors and guests. Welcome to another episode of Warrior1Spine. Actually, the second episode that has been opened up to the general public, i.e. Warrior1Spine is for chiropractors and students that are just passionate about spinal reconstruction and changing people's lives and changing people's stories. Today, Dr. Pascal is going to be leading us through the current research. It's the latest randomized controlled clinical trial on cervical curve restoration. And but first, what we're going to do is I'm just going to actually start off by just sharing a few things here in terms of just setting us up for Pascal's great content. And so what we've done, so last time we were together live actually was about exactly, I believe 9 weeks ago. And between the last episode and this episode, I was just talking to Pascal, is that we've worked really, really hard at getting to the other content up from previous seminars, including some extra content for everybody, which really just helps us kind of go from episode to episode. So make sure you check out the content. You can check it out on the Warrior1Spine YouTube channel. I was just telling Pascal, it's been amazing. There's been, I think we're about to hit about just over 3,000 views. And I know from a YouTube, you know, Gen, whatever we are, that's not a lot, but from a chiropractic engagement perspective, in terms of spinal reconstruction, that's huge. So yeah, make sure you check it out. Also, we were talking to Pascal too, and it's just like, I had a student stop by with a second generation chiropractor who's at Université de Québec at Trois-Rivières, about to graduate, and stopped by with her dad just a couple weeks ago, just dropped in actually mid-shift. And, you know, just telling her about, you know, showing her Warrior1Spine and telling her about the research and stuff like that. And they were really, really pumped. And so we want to make sure that we get this out to students to equip the next generation. Actually, initially to get the next generation to fall in love with adjusting and spinal reconstruction, and really fall in love with, you know, changing people's stories from a spinal reconstruction perspective. Which brings me to the why behind why do Yuri and Pascal and myself take time to do this? Because we do have very, very busy schedules. But this is the why, and it's really simply put. So this is Gerhard, okay? So why I brought Gerhard up is because we talked about Gerhard last time we were live together. And I was relating a story. So Gerhard came in September 2009. This is what he looked like. And, you know, I was like, hey, Gerhard, you know, what we need to do, we need to get your curve back. And Gerhard came in and he was bent over actually his walker. He had a personal assistant full-time that lived with him. I guess Gerhard had some money. The personal assistant, and Dr. Anthony, later on, he can get on, he'll confirm this. The personal assistant was this little Japanese guy, and he looked like he was about 105 years old, but in awesome shape, and didn't speak a lick of English, but understood exactly what we were trying to do. And he reminded me of Mr. Miyagi from the Karate Kid. Like, I'm telling you, like, spit image. So Mr. Miyagi was actually helping me with Gerhard's adjustments. And so the way that Gerhard's first adjustment started is that, in this x-ray right here, he's actually bent over his walker. And then I got him bent over the walker. I don't even know if I took any AP stuff because he couldn't get up. So I took a lateral C, did what I could. So he's bent over his walker in front of the bucky here. And so his first adjustment, he walks, well, he shuffle steps over with his walker bent over it. And I'm thinking I'm going to get him on the table. And, I'm encouraging him, no, Gerhard, we can do this. Well, Gerhard actually, he was sitting down on his little chair, his little seat with his walker, and he stands up with Mr. Miyagi's help. And he shuffles, well, the table's right here, basically. And all of a sudden, he starts dropping. I actually grab Gerhard, I bear hug him, and and Gerhard's not helped me whatsoever. Like, I'm about to drop him. We're gonna go down together. At that moment, I'm holding him, like I got sweat pouring off, like little droplets of sweat. I feel and hear a pop in my lower back. I think I blew a disc. And at that time, Anthony, who was he was a techie at that time, and he was coming out of the room and going, hey, Anthony, we're lit here. And I'm actually yelling at this point. I'm going, Anthony, get over here. So Anthony comes behind me, and all of a sudden, like, I'm the creamy center in the Oreo cookie between Gerhard and Dr. Anthony. And Anthony's actually like strong. So basically I'm holding Gerhard and he's holding me up. And I'm going, oh, this is ridiculous. So we finally get Gerhard sat back down on his walker. And I simply said, okay, Gerhard, you know what? I got a great idea. We're going to try something new here. I haven't even adjusted him. So I actually, from that moment on, there was no way I was going to get Gerhard on the table. So I started adjusting him sitting in his walker. And I just did a seated cervical, C1, C2. And then what I would start doing, this is what we were alluding to last time, is I would start adjusting him standing up. And so we would put him up against the wall. And initially we would actually just get either Anthony or Mr. Miyagi to push his shoulders right up against the wall. And so the contact was shoulder. And after his, seated cervical, I would get on his C1 and actually hit C1. I would hit his shoulder because of the proprioceptors, and I would hit his hip. And that's all we would do because that's all that could be done at that point. And this guy here, like, he would complain all the way through the adjustment. I know that Dr. Anthony's actually, and my response was like, hey, we're trying to save your life, and especially with the double zygomatic arch contact right up against the wall. It's just like, Gerhard, you're going to go from a walker to a wheelchair very soon here. So, like, just bear with me here. I don't care if it's causing you pain. I understand it. I'm empathetic, but I got your future in mind here. So 6 months later, this is Gerhard. This is 3 times a week for 26 weeks. Might sound a lot to some people, not to us, not to Gerhard either, because at this point he's standing up by himself. He uses his walker for a little bit of balance, but he's standing up and he's walking normally, basically with his walker, no more shuffling steps, all that. So 3 times a week for 26 weeks. Once we got him up against the wall, initially it was just, like, as I said, shoulders and double zygomatic. And then we would just use blocks behind his spine. Wherever he couldn't bend, I would just put it below where he couldn't bend and use different size blocks over time as he got better up against the wall. And obviously, too, he couldn't actually do any tractioning. So what we did with him at home is we just did towel traction because that's all you could do. So this is what towel traction. So we get a few different size towels. They bring them in, we roll them up, and we have them progress to more and more diameter. So that's a great story, right? So that's the why behind why Pascal takes the time to go through this with us. And this is the 6-month post X-ray. Stephen, this is Stephen 2003. He came in, he was referred in by his wife who had massive allergies to the point where she had to wear a gas mask at different times. Like, I mean, a full-fledged like gas mask. So he came in with a little bit of sciatica, it would get really bad at times, but, he was saying, I could live with it, and, low back pain. And so he didn't even, back in 2003, he didn't, and you look at, actually, these are old school x-rays. What Yuri and I used to do, this was Dr. Deed's template, the CBP template with massive research behind this template. And we would use our famous wax pencils, our blue and our red. That's what you see on the x-ray there. long story short, Stephen didn't follow through with the 12-month recommendation. He actually, he got to the point where he had no more lower back pain, no more sciatica. So he was happy. He was out of here. Next time I see Stephen, it's 2009, December, 6 years later. 6 years later, he comes in and he's bent over a walker. So this is him in front of his, this is him in front of the Bucky with a 3. Next one is here in front of the Bucky. So he's with the walker. This is him 6 months later, May 2010, okay? 6 months worth of care, 3 times a week for 26 weeks. Is this a lot of care? It isn't for us. Why? Because we know that if he goes from his walker to the wheelchair, he goes into long-term care. He's separated from his wife. His wife can't take care of him anymore. So it all depends on what your why is. So 3 times a week for 26 weeks for us, it's like needs to happen. Towel traction here again. This is Ray, 1998, okay? Old X-ray here. Some of you guys know Ray. Actually, some of you guys probably use Ray with some of your stories when you're first starting out without your own pre and post X-rays. This is Ray, 1998. Neck pain, left arm numbness, 20 years of migraines, 15 years of Crohn's disease. Recommendation, he's a 91, so 3 times a week for 13 weeks. Traction after 6 weeks, twice a week for 13 weeks after that. Post X-ray at 6 months, once a week for 26 weeks. Post X-ray 12 months. And now for some of you old schoolers, you guys would remember some of the stuff that we used to use. And I know, so when back in the late 90s, we used to have this head face kind of harness. It was underneath, there was a chin strap, and we used to load them up, hook these weights on the back of there's a clip, and we were doing it off of the bed. And then we had these weighted headbands too. So they had these big big headband that we could actually slip in. I don't know, Yuri, if you actually remember these things, but we had these weights that we would slip into the headband off the back of off the side of the bed too. And we would just load them up. And some of you guys actually have, the newer generation of tractioners sometimes are a little bit softer than they used to be. And so I don't know if you guys have some people that complain about, how, this hurts sometimes when they start doing it and stuff like that. And, the more that you do it, the less it hurts because of the change. Well, this is one of the things that we used to use. Look at this bad boy, okay? Hard plastic, okay? So if you actually have somebody complaining about this, get them on this for a couple weeks, okay, on the floor. And I guarantee you they stop complaining about the new traction systems. But here again, Ray at 12 months. So this is Ray 1999. Awesome, right? Like, look at that. 12 months back in the late 90s. Okay, which was really like we were ecstatic. That's what built actually give you another one. So after Ray 1999, he goes into his second year. This is once a week for 52 weeks. This is Ray 2000 at 24 months. So after we do the correction 12 months, we go through a stabilization period, which is once a week. Ray 2000, I love Ray 2000 because this is when you and I hit 2000 a week. Why did we hit 2000 a week? It's very simple. We fell in love with actually transforming people's lives. We fell in love with spinal reconstruction. We loved adjusting. We loved being in practice. We loved just being who we were designed to be. So that's Ray 2000. Pretty cool. Well, let's look at Ray 2017. This is Ray at 19 years for some of you at 228 months after he starts care. Ray 2017. This is Ray at 20 years. Okay, I didn't do the calculation for the months there. This is Ray 2018. This is Ray at 21 years. Look at that. Okay, Ray at 21 years. If this doesn't get you excited, I don't check your pulse, right? This is like amazing. This is Ray at 22 years. This is Ray 2020, okay? And you know what? What has to become real for you is not just the stories that you celebrate, that you see, but what about all those stories that you don't see anymore? because their story continues, right? If you don't see them, what happens? Well, Ray, if he's at the beginning of a phase 1 going into a reversal in 1998, okay, he'd be a full-fledged phase 3 22 years later. But look at Ray now. So that's what we do. You know, the biggest thing, and then Yuri's going to start introduce Pascal and share a little bit, but you know, the biggest thing that we want warriors and students, if you were to ask us one thing, like Ed, Yuri, like what has allowed you to be successful in practice, is like, you know what, guys, in life, stay close to your first loves. In practice, simply stay close to your first loves. Never give up adjusting the neck. Love adjusting the neck. Fall in love with spinal reconstruction. Fall in love with changing people's stories. Fall in love with the research that is actually catching up to what we've been doing all along, and even the people that's gone way before us, right? Before us, the ones that were on the cutting edge, and cutting edge looks different along the way, right? But stay current. You guys have the research behind you. Fall in love in what you do, and you're going to actually have a very, very amazing career. And more importantly, you're going to have an amazing legacy behind you. Yuri?
Yeah, awesome. It's actually interesting you're talking about 2000, because this weekend I was preparing for Leadership Summit 2021, and I was reviewing my journal from 2000 and 2001. And you know, what comes to mind is that pretty well all and basically what I journal is my morning time, and it was all about saving lives, right? It was that was a kind of #1 theme. And so you don't know about saving lives unless you have the faith, confidence, and belief in what you're doing. And so you know, it's just super important that we have somebody like Pascal that can come on and help us kind of dissect the most current research. I remember listening to Don Harrison for the first time, and they used to have these biannual seminars and have a bunch of different presenters. But it's just when I heard what Don had done as far as all the research behind the research that allowed him to create, you know, how many years of research to create even just the template, right? And so just we're super excited to have Pascal. I'm not going to take up any more time. I want him to get into it. And so just enjoy some of the newest research that we have from CVP. Go ahead, Pascal.
Thanks, guys. Those are some great cases, Dr. Ed. Love it. I love the first story. Gerhard pushing the cheeks up against the wall. I've done it too. I absolutely love it. Getting the assistant to help you adjust to. Beautiful story. But I mean, you just touched on it. It's exactly that. Is today we're going to be talking about the newest randomized clinical control trial on the Denerol. And it is the fun part is exactly what you talked about. Sorry, here, I'm just going to get to share my screen. And it's getting this evidence that is supporting what, you know, back to the days of DD and BJ and talking about bone out of place causing nervous system interference. Well, finally, you know, 150 years later, we're starting to get this high-end, high-quality, top-notch research that is supporting things that subluxation-based philosophical chiropractors have been telling their patients for years. So I'm really excited about this project. Last time we had our webinar, which was sometime in March, I think, we talked about what spine surgeons were saying about restoring the curve, right? Today, we're going to be talking about what the curve restoration does on the Denerol in regards to autonomic nervous system function and cervical sensory motor control. So this is the 10th randomized clinical control trial that has been done on the Denerol. And I think so far the most exciting, I'll talk about the 11th that's coming out here shortly, which might be even cooler than this one, which we could talk about at a later date. All right, so here is this study, okay? So here's the context behind it, right? Sagittal plane cervical spine alignment has emerged as one of the most important clinical outcomes in healthcare. Yeah, exactly what we talked about last time, right? You've got all these surgeons and different health professionals. When they look at the spine, they know head goes forward, loss of curve, big time health problems. Okay. So there's lots of research to support that, but there's very little research, right? So quantity and quality of research on the role that cervical sagittal alignment plays on improving sensory motor control and autonomic nervous system function are limited. In other words, the research stating that these things play a role in nervous system dysfunction is lacking. So the research supporting the subluxation theory is lacking. So this is a great paper that helps to substantiate our subluxation theory. Okay, so the objective of the study was to investigate the immediate and long-term effects of putting a curve back into the neck and reducing anterior head translation, right? The things that they measured were pain, disability, autonomic nervous system function, and cervical sensory motor control. They did this in athletes, specifically on this paper, with chronic nonspecific neck pain. Okay, so to be included into the study, the patients had to have 1, neck pain, 2, they had to have loss of curve, and they had to have anterior head translation. Okay, so what they do is they have 110 participants and they split them up into 2 groups. So half goes in the control, half in the intervention group. Both groups are going to get seen 3 times a week for 10 weeks. This is how every single dental roll study has been designed so far, right? And we could argue that, yeah, it'd be cool to see studies where they keep seeing them long-term over and over and over. But you have to understand this is research trying to prove the difference between the dental roll and a group that doesn't get the dental roll, right? So they see them 3 times a week for 10 weeks, and then they stop giving them any kind of care after 10 weeks so that they can measure the differences and improvements in these patients comparatively, the ones that got the dental roll versus the ones that did not, okay? So both groups get seen 3 times a week for 10 weeks. The treatment group gets the dental roll, control group gets no dental roll. That's the difference. Okay. They measure them at baseline. They measure them at 10 weeks. So after they've done their 3 times a week, and then they measure them at 1 year follow-up. What they measure are the curve, okay, anterior head translation, neck disability and pain. And then, you know, all this stuff you see here, smooth pursuit, overall stability, blah, blah, blah. It's all stuff indicating how good is their cervical sensory motor control. And then I think lastly, and most important to us, is amplitude and latency of the skin sympathetic response. So determining the function of the autonomic nervous system. Okay, let's just jump to the conclusion, then we're going to dive into the study. What did they find? Okay, restoration of the cervical sagittal alignment in the athletic population had a direct influence on pain, disability, autonomic nervous system dysfunction, and sensory motor control, right? So they did find that there was a significant difference between the 2 groups at 1 year follow-up for those that got a curve versus those that did not. All right, so all of these slides here, the ones that have CBP at the bottom, they're from Dr. D. He gave me permission to use them specifically in regards to teaching about dental rolls and these studies. So how did they measure the autonomic nervous system function, right? So they use the sympathetic skin reflex. This is important, okay? So the study participants show up, they get put into a room that's a set temperature for 20 minutes before they take these readings. So it's a quiet room, same temperature. They tell them, do not exercise, do not drink coffee before showing up. And what you want, and I'll ask this, even though I know you guys, you can answer this, right? So, but just think to yourself, while I'm at rest, do I want a really active sympathetic system or do I want a quiet sympathetic system? I hope everybody's thinking quiet, right? Because if you're sitting in a quiet room, at rest, you should not have a very high fight or flight response. You should be parasympathetic dominant, right? Rest and digest. So if someone has, a high amplitude, right? Amplitude means like how strong is the spike of the sympathetic nervous system. So a high amplitude means you're sympathetic dominant at rest, which is not a good thing. A short latency, meaning the amount of time that it takes to get to the peak.
Can you read this agreement? It's the paragraph I need you to read.
Oh, somebody's unmuted there. I think
Ready,
Dr.
if you
So,
could unmute. Yeah.
you unmuted
Ready.
yourself. So a short latency, right? Or a short latency means the sympathetic nervous system is kicking in early again, okay? So short latency, high amplitude equals bad, means sympathetic dominant at rest, which we do not want. Okay, so what we would want to see if putting a curve back into the neck and reducing anterior head translation improves the sympathetic dominance, it means after they've been improved or after they've gotten their curve, they should have a lower amplitude and a longer latency. Okay, so we'll cover the results in a bit. I just want to show you this is how they measure it. It's amplitude and latency. Balance. So they test their balance. This is a cervical sensory motor control, right? So they put them on this unstable platform. Basically, the platform can move and the platform has sensors. And so it can read the responses of the body, right? And so you get this diagram like this over here. And basically, the more subluxation they have, so the more loss of curve, the more anterior head translation they have, the squigglier the line, right? The further out the perturbations go, it means they're unstable. Their body cannot control itself in time and space because they are subluxated. So in theory, as we improve the curve and reduce anterior head translation, this grouping around the center dot should get tighter. In other words, if they had better balance due to cervical curve correction, you would see basically, much less perturbations around the center like that, okay? Smooth pursuit neck torsion test. So they put these fancy glasses like this on the patient, so they take away visual cues, so you can't cheat with your eyes. And basically what then, the researchers do is they turn your head to a certain position, 45 degrees one way, 45 degrees the other way, and they have you try to reposition. So they call it like repositioning accuracy. So how accurate is your proprioception due to the problems in the neck? So the more problems you have in the neck, the more inaccurate you're going to be in terms of being able to reposition yourself. So as the curve improves, we should see improvements in the ability for the patient to be able to go back to a specified neutral position. Okay, so that's how they measure the accuracy of smooth pursuit neck torsion test. So again, why is this stuff important? Well, I've said it on previous webinars, it's exactly what Dr. Ed was just talking about at first, is because this stuff helps to change lives. And we have a battle in our profession. It's nonstop. And the more research that we get that substantiates subluxation, that supports our position, and it shows that we have this impact on our patients long-term, right? The more likely we are to succeed and be able to dominate our profession. Our school in Canada here, CMCC, has even taken this word out of their lexicon. They don't even recognize subluxation as a word. You've got the pain faction of our profession that wants to adjust people 4 to 6 times, high five, you're out, that it's ridiculous to think about correcting a spine. Well, why is that happening? Because we don't have enough agreement in our profession. I don't agree with my neighbor as to what a subluxation is. How do I measure it? How do I correct it? What effect does it have on that person's health? And this is where I have gravitated towards CBP and Dr. Don, indeed, because they, in my opinion, have done the absolute best job of establishing normal, abnormal, providing this body of evidence that supports subluxation corrective care. We need that agreement, right? Didi said it, BJ said it, bone out of place, puts stress on the spine and affects the nervous system. We've known it in our hearts, we've told it to our patients, and now we have the research that supports and substantiates it. So here is right from the introduction, okay? Sorry, where's my cursor? Although the effects of the autonomic nervous system activity on musculoskeletal function have been studied extensively, there's very little research that supports the idea that the nervous system is intimately responsive to changes in the afferent articular input due to joint dysfunction. All right, what does that mean in English? So we keep saying above, down, inside, out, right? That is kind of a motto that we've been using again for 150 years in chiropractic. But really, it's as importantly outside, in, down, above. For your brain to be able to control every single cell, tissue, and organ in your body, well, it needs to be able to understand. It needs information from its environment to be able to respond. So actually, outside in, down, above is just as important as above, down, inside, out, right? It's a two-way street. And so what they're saying here is joint dysfunction, aka subluxation, is the nervous system, are there effects to the nervous system as we start to get joint dysfunction? So as the spine misaligns, can we show that now there's corrupted information coming into the brain, and then therefore the brain cannot put the proper information back out? And so they're saying there's very little evidence in the literature that supports that joint dysfunction affects autonomic nervous system, okay? So here's the study design. You got 110 people, you split them into 2 groups. Half in your intervention group, intervention meaning the group that gets the dinner roll, half in the control group, okay? Both groups get the same, what they call multimodal program. Remember, this research is being done overseas in the United Arab Emirates and in Cairo, Egypt, by a group of doctors of physical therapy. Okay, they took interest in spinal reconstruction because they are seeing the effects on patients' health long-term. So they do what physical therapists do, right? TENS, they did thoracic spine mobilizations, manipulations, soft tissue stuff, a bunch of stuff to help them with pain. Both groups get the pain stuff 3 times a week for 10 weeks. Only the intervention group gets the dental roll. So therefore, the only difference between the two groups is the addition of the dental roll. They measure them at baseline, 10 weeks, and 1 year follow-up. Okay, I hope that's perfectly clear. All right, so if you're watching this in the background and you're not following along, follow along, because this is the part that substantiates, or this is the part that supports care over time. So at first follow-up, 10 weeks post-intervention, we identified what? A big no. No differences between both groups for most of the management outcomes. In other words, there was no difference in pain, there was no difference in sensory motor control, and there was only differences for curve correction, anterior head translation, and they did see a difference in the amplitude of the sympathetic nervous system, right? So right away, your heart might sink and go, oh, why am I doing curve correction? Because at 1 year follow-up, differences were present for all management variables. These findings indicated that the group that got curve correction had improvements in every single management variable measured, okay, at 1 year follow-up. We're going to come back to these results in a sec. Let's find out why that is. Well, right here, the healing process takes time, right? It doesn't happen instantly. And it's highlighted in yellow. They talk about it in the study. It is surprising that at first follow-up, the intervention group that received the cervical dental roll traction did not show improvements in many variables compared with the control group across cervical motor control outcomes. However, we observed improvement at long-term follow-up, 1 year. We see no obvious unifying explanation for our findings other than to speculate that sustained postural imbalances or sustained subluxations can result in a state of continuous asymmetric and increased mechanical loading, right? Fancy engineering terms for saying subluxation. Empirically, when the asymmetry and that imbalance is corrected, a normal posture is regained and improvements in measurement outcomes are revealed over time. And they're saying, yeah, we've seen this before actually, because Diab and Mustafa, who are Dr. D's colleagues, have done other randomized trials where they see that there are very little changes, if not very few differences at 10 weeks. But over time, what happens every time? The group that gets curve correction continues to improve above and beyond the results that they had in 10 weeks. And the control group, typically any improvements that they had, regress back to baseline. Right? This is the kind of research that we need more of that substantiates the corrective care that we're doing. Okay, so let's go back to this now. So we talked about the sympathetic skin response. Okay, so again, A is going to be your dental roll group. B is going to be your control group. So we talked about it. We want a quiet sympathetic system at rest. So we would want to see, right, a lower amplitude, and we want to see a longer latency if the sympathetic response is decreasing, right? So if we're shifting from sympathetic dominant to parasympathetic. So let's start with the dental roll group. So they had an amplitude of 1.9. So again, that's the height of the peak, right? So the stronger the amplitude, more sympathetic. And they had a latency of 1.1. So at 10 weeks, they've got an amplitude of 1.3. So that was statistically significantly different. So there was a reduction in amplitude. So by putting a curve in, we saw a calmer sympathetic nervous system and a shift to parasympathetic. Now, which is really cool, okay? The latency also got longer, right? That's what we want. So it went from 1.1 to 1.4. But check this out. So even though they don't see them between 10 weeks and 1 year follow-up, the amplitude continued to get smaller. It went from 1.3 to 1.1, right? The healing process takes time. The latency increased from 1.4 to 1.5. The healing process takes time. And both these values are significantly different from where they started, okay? Alternately, the control group, basically no change. They start at 1.3 amplitude, at 1 year follow-up, 1.3. They got a latency of 1.4, and as a matter of fact, their latency gets shorter at 1 year follow-up. No change, if not worse. Okay. The dynamic balance test. So this is only the dental roll group, but I wanted to show you guys that it was exactly what I had discussed on that second slide. So you see at baseline, there's all kinds of squiggly lines, right? They're way off. As we improve the neck curve, as we improve the anterior head translation, they get much tighter groupings, right? So they stay within the A circle. And then at 1 year follow-up, even tighter, even better balance at 1 year follow-up. Okay. Very cool findings. All right, so basically, how do we describe this? Or let's go through every section. We're going to talk about pain, disability, sensory motor control, and autonomic nervous system function in terms of a discussion. Okay. So basically what they're saying here is, yeah, we can confidently state that the changes that we see, right, in pain, disability, nervous system function, motor control can be attributed to the curve correction. And we're the first ones to prove that this happened. Okay. So this is a novel study. It's the first time this has been proven or documented. This here, again, if you're not following along attentively, pay attention, because this is what sets you up. This is what separates you as a corrective care specialist. This is what makes us different than those pain-based chiropractors. Multimodal program alone, right, or in conjunction with the dental traction, was roughly equally successful in improving the participant's pain and disability after 30 treatment sessions. Okay, what does that mean? In other words, regardless of what you do typically, you know, rub this, adjust this, dental here, almost always patients get well in the short term, right? There's a short-term effect. So they're saying that even by improving the curve in the short term, there is virtually no difference between the two groups. Okay. In contrast, at 1 year follow-up, right? Well, hold on, before I even say that. So let's go, a pain-based chiropractor, what's the argument? Well, I adjust them, they get out of pain, you put a curve back in, the pain results are the same. So someone would say, well, why would you x-ray them if changing the curve didn't make a difference? You know, why would you keep saying them after, 10 weeks or after 30 visits if correcting the curve didn't make the difference, right? So if we're not doing any long-term follow-ups, well, those pain-based chiropractors have a very strong argument. When we're measuring pain levels, whether or not you correct the curve in the short term, it makes no difference. But when you go out 1 year and you measure them, now you see that at 1 year, guess what? The control group that didn't get curve correction, they regress back to baseline. The group that got the dental roll, they just continued to improve and get healthier and better over time. Okay. So this again is what helps support long-term care, keeping patients in your office. And this is when someone asks you, doc, it's been 5 visits. How come I'm not well yet? Well, that's why you're on a plan. Healing takes time, right? This is why healing takes time. 1 year follow-ups. Motor control. Okay. We talked about the improvements in motor control. So we know that improving the curve and decreasing head translation improves motor control. But someone could argue, right, if you don't do the right statistical analysis, that it's just association, not causation, right? There's a difference, correlation versus causation. Like people can say, yeah, there are more shark attacks when basically the temperature rises. So you could correlate, as ice cream sales go up, there's more shark attacks. Well, that's a correlation. It's not a causation. So how do we know if the sensory motor control improvements were directly due to the changes in the curve and anterior head translation? Well, they can run linear regression analyses. So basically, they can look at the larger the head translation, the more loss of curve. So the more subluxated and deviated from normal you are, then you would have the poorest results on the balance tests, on the repositioning accuracy. And then vice versa, as we correct those, so basically the larger the correction, the more improvement that you have, then we should see stronger improvements on those motor tests post-treatment or at 1 year follow-up. And that's exactly what Dr. Dean and his colleagues saw. A linear relationship between the amount of dysfunction and the amount of measurement of subluxation on x-ray. And again, the amount of correction and the amount of improvements that were seen as they improved the head translation and the curve correction. So very cool stuff in motor control. And then the autonomic nervous system function, well, we saw that it improved the sympathetic skin response. It improved the latency of the sympathetic nervous system. So basically we're seeing, and what they are saying here is supporting, their findings are supported by Welsh and Boone, who concluded that cervical adjustments could manifest a shift to parasympathetic dominance, right? And then here's the mechanism. Considering the close proximity of the cervical spine to the brainstem region, restoration of a more normal anterior head posture and cervical lordosis may improve parasympathetic activation and decrease overall sympathetic tone. And that's what they measured, okay? So how does that happen? Well, reducing the adverse mechanical tension acting on the brainstem and cranial nerves, 5 through 12, but specifically the one we would be interested in, again, is that vagus nerve, number 10, which is involved in and responsible for parasympathetic communication or parasympathetic activation. So you reduce the tension on the brainstem and cranial nerves, you reduce the interference to the vagus nerve, and as a result, what happens is you get improved parasympathetic tone and reduced sympathetic tone. right? Very cool. Very, very cool. I hope you guys are excited about that study as I am, right? It's quick. We're not going to spend much more time discussing it than that. But just to say that again, support those. If you're doing correction and you're using still one of those old plastic correctors that Dr. Ed showed you, and you're not using, yes, the new soft, nice, cushy dental rolls, please get on it, guys. And there's a reason to use those, is because that money, what you're supporting, goes to providing research like this, exciting research that supports you in what you do every day and keeps subluxation alive to allow us to continue to practice and help people in our clinics every day. The next randomized clinical control trial might be even more exciting. I alluded to it. They're taking asymptomatic subjects, right? So not pain this time. And they're doing the same tests that they did in this one, but they're also adding cervical curve conduction. In other words, they're looking at the speed from which the brain can send information out into the extremities. And I know Dr. Deed already has the results. He's told me about this. Preliminarily, it's not published yet, but they're showing that they're getting up to a 10% improvement in central cord conduction time. It's 10% faster. So you get an improvement in 10% in how your brain communicates with your body by correcting the curve. That is exciting. That is pretty cool, right? So talk about research that supports subluxation. It's exciting. It's coming out, and I'm sure we'll talk about that one at some point in the future when it is published. So once again, that's what I had for you. We can open up for questions in a minute. As always, it's a thank you for being on the Warrior webinars and letting me be part of this team and group for reconstructive spinal reconstruction of the cervical spine. Here's a coupon code that all the Warrior docs can use to purchase dental products. That's where you get them. My contact information in case you want to email me cases. And then lastly, the YouTube videos to show you how to use some of the products, exercises, and so on, so forth. So we've